it sounded just so common sense. And I think we don't have enough of that. We're often quite kind of do what we always do in prescribing and all kinds of medicine. I look after quite a big elderly population. I've been the lead GP for a care home for some time. And I'm the clinical lead for frailty in my area. So I've kind of got a big interest in looking after frail people as best we can. And obviously they're a big group that the deprescribing is targeted at. So yeah, it sounded like a very common sense and practically useful approach to developing practice. Enthusiasm, actually, is one of the big things. Like it really, it kind of gave me permission and motivation to kind of do some of the slightly more in-depth and more difficult things in terms of having more of a conversation with people before I start meds about the potential risks of them. You know, I learned some things I didn't know, embarrassingly. I've been GP for 7 years and a doctor for 13, and you know, still I think you get into the habit of, you know, well, X is the treatment for Y, without necessarily each time thinking through or indeed discussing in detail some of the potential downsides of taking medication. So that's one thing. I think that's definitely developed my practice in terms of thinking twice before I start drugs, but also, for example, when I'm processing sort of monthly prescriptions for my care home residents, I have a much lower threshold for kind of trial without X, Y, or Z drug. You know, I've been routinely reducing the dose of PPIs that people have been on for a long time, and you know, discussing with families and patients and care home staff, well, actually, if we're not sure if this is doing any good, maybe we could try without it and see. A lot of the things that we discussed on the action learning set were very simple changes, and you know, it's not all about massive medication reviews and convincing people to stop things that they've been taking for years. Actually, some of it is very simple. Some of it is, by the way, there are risks associated with this as well as benefits. And, you know, I think we should start this as a trial and deliberately review it in a few months rather than just put it on repeat and forget about it. And another great thing about the course is, you know, the wealth of resources that, you know, I've been directed to. And, you know, it means that pretty much any of these decisions, I can point at a source and a respected, well backed up source that says this is a good thing to do and this is a good reason to do it. Combine that with the sort of the expert forum at the end, which I think everybody probably says the same. That's incredibly useful. It's really, we don't get enough opportunities to have quite frank conversations with clinicians from other disciplines. You know, being in a group with pharmacists and seeing the kind of understanding the differences in our practice better is really valuable. So the group is what makes it. You're not going to come away from it thinking I haven't learned anything today. It is advanced training. I think it's more of a confidence thing, feeling like I've got this resource behind me and a group of respected clinicians behind me saying this is a good thing to do. This is not you know, going against guidelines. Actually, this is eminently justifiable and is not only okay to do, it's probably desirable to do. The confidence to individualize treatment and to advocate for the patient experience of that. The real value of the Polypharmacy ALS is the encouragement and tools to have a more nuanced conversation about proposed treatments or ongoing treatments, and to be able to make a decision together with the patient rather than more in opposition. And sometimes that doesn't work out because sometimes patients just want you to decide for them, which is fine. It's really encouraging to be reminded to come at it from your patient's point of view rather than the NICE guidelines point of view.